Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
So let's sit down. It's truly my pleasure to introduce Dr. Brent Ward to you. Many of you know him, but Dr. Brent Ward is an assistant professor in the Department of Oral and Maxillofacial Surgery, School of Dentistry, and also in the Department of Surgery in the School of Medicine here at the University of Michigan. He's also the program director of the Maxillofacial Oncology and Reconstructive Surgery Fellowship here at the university. Dr. Brent Ward clinical practice is focused on the treatment of cancer and precancer, as well as minor and major reconstruction of structures of the face and jaws. He's a member of the University of Michigan Nanotechnology, where he's doing research on targeted chemotherapy, as well as pain management. And in both cases, the key issue behind, the key attempts behind Dr. Ward's work is increase efficiency and safety for patients. Clearly, Dr. Ward is a superstar in the field of oral and maxillofacial surgery, both from the clinical perspective as well as the research perspective. Dr. Ward will talk with us about surgical management of oral cancer and the array of reconstructive options available for patients with oral cancer. Let's please welcome Dr. Brent Ward.
Thank you, Jacques. Very kind. If I'm a superstar today, I'm feeling like a very small fish in a big pond. When I was a student, the book I used for one of my favorite courses in dental school, which was oral pathology, maybe not a surprise, was the book by Dr. Schuba. And I actually went to the hospital so that I could be pimped incessantly by Al Abrams and Janice Handlers because of the intellectual stimulation that occurred when they were asking me those difficult questions. When I came into residency, I again had the opportunity to learn by the Socratic method. And the best thing about the Socratic method was when I went home and read 3 or 4 papers, the next day I could come back and fight. So I'm going to talk to you today about surgical treatment of the maxillofacial oncologic and reconstructive surgery patient and where we are today and where we're going. And we'll do that in a broad enough way, I hope, that it will be applicable to you. If I just told you about surgery, it'd be applicable to hopefully 5 or 6 people in the room. I'm going to talk to you about more than that, so that it applies to your practices and what you are doing today. In doing so, I'll use a backdrop. I have what I call my 10-minute cancer talk, and I use that on a routine basis, almost weekly, with my patients. I'll sit knee to knee with somebody, and I will tell them that they have cancer. And I will talk to them about what that means. What does that mean in regards to staging, the endoscopy, the imaging that we're going to do, the serology or blood work? What does that mean regarding etiology? Now, I can't tell them very much about the etiology in many cases, but I certainly can tell them that smoking and alcohol are known factors associated with oral cancer, and therefore I can tell them they need to be careful in the future since they now have a cancer diagnosis. In 2011, if they have oropharyngeal cancer, I can talk to them about HPV. And before we're done, I think you'll understand the importance of those conversations and how that's changing how we think about oral and oropharyngeal cancer as a whole. I can talk to them about the treatment of the primary disease and the treatment of the neck. I can talk to them about their reconstructive options and ultimately tell them how we're going to figure out what their prognosis is. So a few months back, a patient kind of talked back to me. And here was the question. He said, "You mean to tell me, Dr. Ward, that in 2010, with all of the medical advances I'm reading about, there's nothing more you can tell me about my disease and prognosis, and nothing better you can do than take my leg and make me a jaw?" Now, I take a lot of pride in taking legs and making jaws, but he was right. He was reading about prostate cancer and what Dr. Polverini showed you about survival rates in prostate cancer compared to oral cancer. He was reading about breast cancer and how receptors and hormones were changing the treatment of individuals and changing the prognosis. He was right, and I had to take a step back and recognize that he was right. Let me give you an example. Here's 4 of my patients. All of these patients present with a tongue lesion. Some of these tongue lesions look similar to what Dr. Shuba just showed you. But the question is, does it matter which one of these patients has which disease on the left-hand side? Does it matter if this guy has this or this? Does it matter if one's been a smoker or not? Does it matter their age or their sex or their racial status? And the answer is, for oral cavity cancer, nope. For oral cavity cancer, I'm going to treat this by removal. And it really doesn't matter to me which one of these people has which one of these disease, because the treatment I'm going to give them is the same, because I don't have a way to distinguish them. If I globalize this to another place in the oral cavity, does it matter for a mandibular cancer if it's an African American, an Indian, or a Caucasian? Does it matter which of the sites they have? Does it matter that one's female? Does it matter what their ages are, whether they've smoked? And the answer, again, globally is no. We don't know enough about oral cancer at present to make a distinction. And I don't mean to belabor this, but I can choose a subsite, and the answer remains the same. My treatment is going to be based on the primary disease and not based on something that I know scientifically about them at the present time that will significantly guide that. That is with an exception, and the reason I included a picture here in the lower right-hand corner. Take a close look at that one, because that one is a game changer. That's not oral cavity cancer anymore. That's oral pharyngeal cancer. And oral pharyngeal cancer, even though it's only moved back a centimeter or two, that's a different disease. That I know that HPV might be related. That I know if you've never smoked, you're much more likely to have HPV, and that might change the treatment that I will give to you. So move the lesion 1 centimeter back, and I know something genetically, I know something about your demographics that will make a difference. Move it a centimeter up into the oral cavity, and I'm completely lost. I remind you that primary staging results from looking at the patient, their T stage, which is their primary tumor, the size of that, a T1 being less than 2 centimeters, T2 growing larger than that, T3, etc. We also look at lymphatic staging. The lymph nodes are incredibly important when it comes to prognosis for our patients. We look at the possibility that they might have distant metastatic disease. And the chances of them having distant metastatic disease, if they're a stage 1 patient by TNN criteria, is only 1%. But as we progress in our size of the lesion, and as we progress in lymph nodes being involved, then the chances of them having distant metastatic disease, which is always basically an end-game process that leads to demise, increases. What is the effect of early diagnosis? And the students are going to recognize this slide. It's spruced up a little bit since your lectures. But the effect of early diagnosis is survival. If I can have a diagnosis that's early, then I've got a better chance at this patient being a survivor. Not specifically as an individual, but I'm going to look at as a population. If I can get this in a T1 or T2 in 0 stage, stage 1 or 2, then I have a 70 to 90% chance of 5-year survival for this patient. Some of them will die of their disease. Rates are listed up there. If I get them as a stage 3 or 4, so a T3 or 4 lesion, any lymph node involved, then their chances of 5-year survival are 10 to 40%, drastically different. And over 50% of them will die of local recurrence, meaning the disease will come back in the same place I did their surgery. This is not just letting the disease go on. This is after my treatment. This is after I walk out of the operating room and say, we've been successful. And yet, 10 to 40% 5-year survival for these folks after my successful surgical intervention for them. Now, the answer to that might, we think, be mass screening. There are a few screening trials. This, the largest that was ever done in the world, almost 200,000 patients that were screened for oral cancer, this done in India. And the asterisks mark areas of statistical significance. So they had a bit of a stage shift. Screening helped them identify more stage 1 and stage 2 cancers. That's obviously good. It increased their 5-year survival. That as well is good. But when they looked at who it was that benefited from screening, it was only high-risk men with smoking and tobacco histories. everybody else that was screened, it didn't make a difference in their mortality. And you need to understand, and you need to critically think about literature and about populations, because this was completed in India. In India, the prevalence of disease, and you can't make this out, I don't think, but the prevalence of disease in India for oral cancer is twice that in the United States. So would the same screening trial on a population where the prevalence of disease is only half of what it is in this trial show the same result? And the question and answer is probably not, hasn't been done, we're not sure, but you need to take that into consideration. The screening oral exam overall has a sensitivity of about 60%. Some of the smaller trials have said it's up into maybe the 80s, but these larger trials have said that screening works about 60% of the time. That means that people who developed cancer had a screening exam soon before that, and it was felt that the lesion was missed. The specificity of a screening exam is pretty good. That means when you and I look in the mouth and say, boy, I think this person has a really big problem and this is cancer, we do a generally good job of that. What we don't do a good job on is finding the small lesions, the early lesions, and getting them to somebody who can help them with their disease. This is a quote from 1949. Hayes Martin, a head and neck surgeon, renowned world-class head and neck surgeon from Sloan Kettering Cancer Center. He said, if the possibility of a serious disease is realized at the first visit, the major difficulty has been overcome and the problem is well on its way to being solved. If the individual dentist or physician who first sees a patient with mouth cancer has a sound, basic knowledge of this disease and suspects a diagnosis. Who is it that might be able to have a sound, basic knowledge of the disease and suspect a diagnosis? I would suggest to you, and I will show you data that supports this, that that's the dental profession, unquestionably. So this is a group of patients, 51 patients out of Oregon, to some colleagues of ours. Dr. Holmes is the lead author, reported in the Journal of Oral and Maxillofacial Surgery. And this study looked at how patients were referred to them. These were individuals who were actually dual boarded as oral and maxillofacial surgeons and otolaryngologists. They were getting referrals from medicine, from dentistry, both. When they looked at their patients who had no symptoms at all, the dentist made up the vast majority of the referrals for those types of patients. The hygienist, a small number, oral surgeons, and then denturists. So every patient that did not have symptoms, who had their disease picked up, was picked up in the dental setting. For patients that had symptoms, so something's hurting my mouth, I'm going to go see someone about it, for those folks, 55% of them were dentists, 21% primary care, 12% ENT, 12% oral and maxillofacial surgeons. So if you had symptoms, you went one or the other way. But those that didn't have symptoms and had their disease picked up was universally in dentistry. If they looked at regional specialists, somebody that worked in the mouth every day, so the entire dental profession and the very few patients that were diagnosed by an otolaryngologist, all but one of those patients had their disease picked up at the first visit. They were referred either for biopsy or had a biopsy on that first day. The non-regional specialist, meaning the primary care, only 50% of the time did they pick up the disease. Sound knowledge of disease and a high suspicion, okay? Sound knowledge of the disease and a high suspicion. That obviously was not taking place in a population where half of the people, it was felt that their disease represented something different. When they looked at the clinical stages from the primary care setting, there were about a quarter stage 1 and stage 4, with almost half of the patients being stage 3. So 75% of these patients had a 5-year survival of 10 to 40%, regardless of whatever surgical intervention they might get. In the dental setting, it was exactly the opposite. 75% of the patients were in the stage 1 and stage 2 categories. So these were folks with 70 to 90% survival. So who needs to diagnose this disease? Who needs to find it early? Absolutely, it's the dental professionals. And it makes sense, folks. You saw on the first slide, I'm a DDS and an MD. If I were talking to the MDs, I would say the same thing. We work in the mouth every day. That is what we do. And because that is what we do, we can have a sound knowledge of the disease. We just need that high index of suspicion. Now, the problem is this piece of data that the students haven't ever seen and is a bit of a sobering piece of data that you have to think about in the process so that you won't become discouraged. This is from Brad Rodeau and Philip Cole. And they took a look at the SEER data, and they looked at the incidence of disease and found 30,000 malignant neoplasms of oral and oral pharynx. It's a number that we all know. Residents can regurgitate that number to me if I ask them. Then they looked at how many of those would be visualizable in a standard oral examination. So they threw out the base of the tongue, they threw out hypopharynx, and then they said, well, how many are left? And the answer was about 21,465 patients. Now, if you take 21,465 and you divide that by 128,000 general dentists in the nation, then the average general dentist will see an oral cancer once every 12 years in their practice and make that diagnosis. Now, we know it doesn't all come from dentistry, so if I throw Dr. Holmes' data in there, once every 15 years. So we're expecting you to make a diagnosis, an early diagnosis, once every 15 years in your practice for a disease that you need a sound basic knowledge and a high index of suspicion. But on average, only once every 15 years will you actually see this. Okay? So is it a complex problem? Absolutely. It's a difficult problem. It's a difficult problem. It's difficult to maintain a high index of suspicion for something you're only going to see once every 15 years. But that is the charge you have. That is the only way at present we have to save patients' lives. Diagnostic adjuncts are available. We're sitting in the room with a man who brought this one to us in the form of a randomized prospective trial. That's Dr. Shuba, and I absolutely applaud him for the efforts and everything he did to bring that to us. These diagnostic adjuncts have a difficult problem. Again, once every 15 years on average, you may have a population with a little higher risk or a little lower risk, but once every 15 years, if we talk just about cancer, that's your chance of detecting disease. Now, some of these help us pick up dysplasia also, and so therefore, we're talking about a higher prevalence and a higher chance on a year-by-year basis, but the dysplasia numbers aren't really numbers that are well-known or published, so it's hard to make those assumptions. The diagnostic adjunct I use is toluidine blue. It's not Visalite Plus with toluidine blue. It's the big bottle of toluidine blue that I can give a little bit to each patient at almost no cost. I don't really use it as a screening tool. Even in my clinic, where the risk is incredibly high for cancer, in my clinic I pull it out once or twice a month to assist me in making a diagnosis or deciding to do a biopsy or not, or where I should take that biopsy. So diagnostic adjuncts, important, something we absolutely need, and something you need to understand what it is and how it's going to help you if you are going to embark on using one of them. Etiology, you all know, so smoking, 90% of oral cancer patients are going to be smokers. The smoking rates in the US have continued to decline, and so there actually has been a slight decrease in the numbers overall, but we're picking up other numbers, as we'll talk about, from the HPV population that are still making the global numbers for oral cancer be somewhat static or increasing slightly. Hollywood is not helping us out very much in this regard. 75% of teen films still show an actor smoking in it. Alcohol in moderation is not a risk factor in and of itself. But high alcohol intake, meaning 4 or more drinks per day, has a relative risk of 5.5, and it's synergistic with tobacco, which means smoking and tobacco together, relative risk 22.1. Smokeless tobacco, I throw this up more for the controversy, and maybe it'll be a fun part of the panel discussion. You know, smokeless tobacco in regards to cancer risk, the data really isn't there. This is a cohort study from 7,000 patients. No significant increase of cancer in males or females. No synergistic effect with smoking. The NCI still says, you know, tobacco and oral cancer are related. We haven't had data in many, many years to support that. And so maybe that can be a topic of conversation that we discuss at the end. This brought to us in 2007 as a case control study of human papillomavirus and oral pharyngeal cancer is that game changer I was talking about when I showed you the oral pharyngeal and the difference that that would be. This showed that 26 or more vaginal sex partners or 6 or more oral sex partners would increase your odds ratio by about 3 for the development of this type of cancer. In addition, the non-smoker, non-drinkers odd ratio for HPV-related cancer was an odds ratio of 33. So this means that the patient that comes to see me with oropharyngeal cancer, who's a non-smoker, non-drinker, is now a different person than the patient that comes to see me who has a smoking and drinking status. This means I might treat them differently. And at the moment, I might treat them differently in a clinical trial, but in the future, that might be a treatment that is available to all. This finding has been corroborated in a number of different subsequent studies, including the CDC's publication recently that said, we postulate that increased incidence of oropharyngeal squamous cell carcinoma in the United States and some countries in Northern Europe is because of a new, primarily sexually transmitted HPV epidemic. This is the silver lining in the HPV story, and that is HPV positive. If I look at overall survival and disease progression-free survival, here's HPV positive, here's HPV negative. HPV positive, HPV negative. If we look at a genetic surrogate, P16, which is how we determine HPV status, is by a biopsy and a genetic surrogate, the same trends are there. So if you are an oropharyngeal cancer patient who is HPV positive today, you might be able to enroll in a clinical trial here at the University of Michigan or across the nation in which you will get less radiation or less chemotherapy. So we will de-escalate your therapy and make it less toxic for you because HPV is so readily treatable, unlike non-HPV related disease. So in oropharyngeal cancer, if my patient had oropharyngeal cancer, I could have told them, well, you know, we can take a biopsy and that might change the treatment you're given. Again, in oral cavity, I don't have those types of markers and I don't have that ability. But there is, and I don't know if I'd say an epidemic, but there is an increase in a population of oral cancer patients that we don't understand what is going on. So young women, non-smokers, not people who have classically been affected with oral cancer, are presenting with oral, particularly tongue, oral cavity cancer. We don't think it's HPV, but we're not sure what it is. And at present, certainly that's one of the quests, is to figure out why are we seeing a different disease in oral cavity, just like we've begun to see a different disease in the oropharyngeal cancer population. Now, the treatments of the primaries are also different. So if you have oropharyngeal cancer, you're going to be treated primarily with chemo and radiation therapy. If you have oral cavity cancer, your treatment primarily will be surgical. We will offer you radiation, and we will offer you radiation and chemotherapy for very specific purposes. Radiation is for T3 and T4 status, N2 or N3 nodal disease in levels 4 or 5 of the neck, perineural invasion, or vascular embolism. When we come to chemo and radiation together, you're going to be offered that if you have what's called extracapsular nodal spread, cancer growing out of a node, or if you have a positive margin. So at the end of our surgery, we haven't been able to get all the cancer out. So again, oropharyngeal, treating you different than oral cavity, because I have more answers in oropharyngeal, and its treatment is more amenable. Neck dissection remains an important and critical part of staging and treatment of our patients. T2 or above, the patient is going to get a neck dissection. A palpable or radiographically positive node, as shown in the CT scan here, they're going to get a neck dissection. Depth of invasion greater than, and I put a question mark because in the literature you can go anywhere from 2 to 6 in regards to what that depth of invasion needs to be in order for a neck dissection to be appropriate. This graph here from the group at Maryland showed that 2.2 millimeters was the depth of invasion that they felt gave the greatest sensitivity and specificity, true positive and false negative rates. And so their recommendation was 2.2 millimeters invasion and a neck dissection would be appropriate. Our neck dissections remain radical neck dissections. That's levels 1 through 4, cleaning out all of the lymph nodes in the neck in those levels 1 through 5. I think I said 4, 1 through 5. And as well, the sternocleidomastoid, the internal jugular vein, and the spinal accessory nerve. For the modified radical neck dissection, we're going to save at least one of those 3 last structures that I mentioned. Then we have the selective neck dissection. That's where we're going to go to specific nodal groups depending upon where that oral cavity cancer is. And we have our extended, which is 1 through 5, plus something additional to that. Reconstruction is where I spend a significant amount of my patients in that knee-to-knee discussion, talking to them about the options that are available to them. We have a variety of reconstructive options, grafts, we have flaps, local flaps, flaps that come from other parts of the body. And in 2011, we have free tissue transfer, which has really given us an additional tool that is being utilized to benefit our patients in regards to functional and aesthetic outcomes. So our tools available, grafts, pedicle flaps, free tissue transfer. We have really unique training as oral and maxillofacial surgeons in that we can begin with the end in mind. Contrary to popular belief, we still remember something about occlusion. All right? We know a little bit about implants and the requirements of implants and where bone ought to be for an implant to be placed. We can visualize that and try and position our bone so that implants can be placed appropriately down the road. And in 2011, the majority of my patients' defects from resection are being closed using free tissue transfer. Now, it was not that way when I began on faculty in 2003, and I credit this group of individuals. Outside of myself, I was an observer and enjoying watching the energy and enthusiasm. But this group of individuals, a microvascular surgeon from China, a fellow from Argentina, a chief resident who was kind and gracious enough to come back and be one of our faculty and one of our champions of free tissue transfer today, and of course, our boss, who performed the first free tissue transfer in the state of Michigan by an oral and maxillofacial surgeon. He was to be followed by the first free tissue transfer in the state of Texas by our recent fellow Fayette Williams, by the first free tissue transfer by an oral and maxillofacial surgeon in the armed forces by a previous fellow Rob Laughlin, and the first free tissue transfer by an oral and maxillofacial surgeon in the country of Argentina by this gentleman, Max Diamante. Free tissue transfer has made it possible for us to move a distant part of the body to the head and neck region for reconstruction. And that has dramatically increased the options that we have available. We don't have to be close to the head and neck anymore. We can be distant. And the distance and the experience that we have with these techniques includes the radial forearm, the iliac crest, the fibula, the lateral thigh, the scapula, and the latissimus dorsi, in which we continue to use that as a pedicled flap rather than a free flap. All of the others are brought into the oral cavity by free tissue transfer. This is us working in the operating room. One of the advantages of this technique is that you can work in two teams. So someone can be working at the leg, harvesting a fibula, while someone else is at the head and neck area doing the resection and doing the neck dissection. The vessels have to be put back together. These vessels can be a millimeter in dimension. 6 to 8 sutures going in them, obviously under the microscope. In order to accomplish this, there are flaps available to us with soft tissue as well as flaps available to us with bone and soft tissue bone together. The advantages of free tissue transfer are the wide variety of available tissue types, a large amount of composite tissue, meaning bone plus soft tissue and skin potentially together. These can be tailored to match the defect. There's a wide range of bone and skin characteristics, and we can perform immediate reconstructions for the patients so that these are reliable enough to withstand radiation therapy. So you come in for your cancer resection and reconstruction all in one shot. The disadvantages, it is technically demanding. It increases our operating room time, and it lengthens the hospital stay. And one of the disadvantages, one of the surgeons that I was fortunate to be learning from in China back in 2003, it takes a little bit longer and can be a bit tiresome and a bit more commitment from those who are going to embark on using free tissue transfer for their patients. In the realms of soft tissue only, our radial forearm is our workhorse. The anterior lateral thigh and vastus lateralis are other options. I've shown you this lady's tongue already. This lady's tongue is squamous cell carcinoma, and the entire dorsal surface of her tongue needs to be resected. Here's the resection taking place. Here's the top dorsum surface of her entire tongue on the back table. A radial forearm can then be harvested, and that radial forearm flap can be brought to the oral cavity, placed on the top of the tongue, and I can assure you in 2003, I didn't have this type of option available to me. In 2003, as a department, we performed 3 free tissue transfers, 2 of them on our own and 1 with the plastic surgery service. In this academic year, we'll do somewhere between 60 to 80. This is her immediate postoperative result, long-term postoperative result. I think the most common question I get is, what about taste? And the honest answer is not much, okay? Residual tongue or taste buds in the posterior tongue that might offer some taste, but not very much taste in regards to having that radioform free flap on the entire dorsal surface of her tongue. Here's a smaller defect on the lateral tongue. You can see some significant swelling of the tongue here. Over time, that resolves. We do see more swelling with these techniques than we see with others. So I tell my patients, there's a bigger initial commitment for you, longer hospitalization, longer operation. But in the long run, if you'll give me a year, I think you'll have a better outcome with free tissue transfer than with the other options that I may have to offer to you. Here's a very large cancer, T4, N2C, tongue, base of tongue. This is reconstructed with a lateral thigh because the radioforum does not provide enough soft tissue bulk to help us in this endeavor. This is a mandibulotomy incision, a near total glossectomy. We're leaving just a little bit more than a centimeter of the tongue as we go back. Then the mandibulotomy, you can see that resection goes all the way down to the vallecula. This is the epiglottis here. And so all of the tongue above the epiglottis has been resected, leaving a very small strip. This is the tongue on the back table with this associated neck dissection and a lateral thigh flap being raised. These lateral thigh flap are on the vessels from the femoral system and allow us to raise a thigh flap that has skin as well as muscle for the bulk that is needed for reconstruction for this patient. Here's the reconstruction in place. We're reconstructing the tongue, the floor of mouth. We're reconstructing the anterior tonsillar pillar. And as I had shown you in the previous photo, this is going to go all the way down the vallecula, all the way to just on top of the epiglottis. Now, of course, the questions are, what about eating and speaking? The answer is speech is going to do pretty good. He's, no question, going to be intelligible. Are people going to know that he's had a surgery? For sure. Swallowing? Probably not. Probably G-tube dependent for the rest of his life, because we're not replacing muscle with muscle. We're replacing bulk. And for individuals where there's not enough tongue muscle to move the rest of that bulk, then we don't expect that to be very dynamic. Here's an N4A or a T4A N2C of the left maxilla and cheek, either synchronous lesions, most likely, synchronous meaning two of them developing at a similar time, or a lesion that traveled onto the maxilla. In this case, we're going to use the two techniques together. So this is a large resection encompassing the cheek and encompassing the maxilla. This is a large defect to close and to try and give her an aesthetic outcome. The vastus lateralis muscle is used in this occasion, and the vastus lateralis with its vessels are transplanted up, again using microvascular free tissue transfer. At the same time, we harvest a radial forearm. That radial forearm flap, in this case, is going to be to use for the skin defect. So we have the vastus lateralis here going inside of the mouth, closing our maxillectomy defect, and providing an inner lining of the oral cavity. And then for the skin, we're going to put the radial forearm flap on for their skin portion. So this is one of the not too frequent occasions in which we actually utilize two free tissue transfers at the same patient in the same setting, and these tend to be relatively long surgeries. This is her at 2 weeks post-op. And if any of the residents have a picture of her, I want it, because she actually looked very, very good in regards to her surgical outcome. She's passed away already, but she looked very good in regards to her surgical outcome. Bone-containing flaps, fibula, scapula, DCIA. Fibula here is our workhorse. We bring the fibula up with the perineal artery and vein. We bring that up into the head and neck region. We can use this with or without a skin paddle. The fibula here is coming from the right-hand side all the way back and encompassing the back portion of the mandible. This is the skin paddle in place in the oral cavity with the sutures, so this is a couple of weeks out. This is an example where we have a large composite defect. This defect, the fibula skin, isn't enough to allow for closure of the cutaneous defect, the skin defect, at the same time that we're using the bone. And so in this case, we're going to go to the scapula because the scapula has that possibility. So the scapula here, we see a nice large skin paddle, lots of muscle that we can use, and the bone is down in this area here, the vessels there with the vascular pedicle for transfer. Here's the bone. The bone of the scapula, generally speaking, is not the stock that we find with the fibula. We've been successful, as I'll show you shortly, of putting endosseous implants in the scapula as well. This is him postoperatively and his immediate postoperative result. This young lady has a mucoepidermoid carcinoma of the maxilla. And again, a mandibulotomy excision. For her, also, scapula was the right way to go. And so we used a scapula flap similar to what you had seen before. This is her immediate postoperative result. Reasonable profile, lots of flap inside of the mouth. And so we go back 6 months later and debulk that flap. And at the same time, we're able to place endosseous implants for her. So she now has 6 endosseous implants, and 6 months from now, the wizardry of Dr. Sam Schwetschenbaum, our maxillofacial prosthodontist, will help her to have a fixed prosthodontic reconstruction from a major cancer operation that took much of her maxilla. Our goal for all of these patients, especially when we're doing our bone reconstructions, is to position bone in a way that allows us to place endosseous implants for ultimate functional rehabilitation of the patients. This, a gentleman with a metastatic melanoma to the jaw, actually ended up being a case report for us in the journal because this is very rare. But this metastatic melanoma of the jaw resected, a free fibula put into place, and ultimately implants and a reconstruction with a bar over there. I told you we know something about occlusion. This was replicating his preoperative occlusion, just want you to know. Dr. Z did a very nice job. Where's Sam? Somewhere around here. So yeah, this was replicating his preoperative occlusion. He wasn't left with an open bite because of some misadventure in prosthodontics. 22-year-old female with a cancer of the mandible removed and resected, taken out on the back table, a fibula reconstruction for her, postoperative radiotherapy. These slides and the ultimate dental rehabilitation were actually done in New York. She was a graduate student here at Michigan. She transferred to New York after that, and Dr. Bookbinder and Dr. Okai were kind enough to send these slides back to us to show us the results of their treatment. They used computer imaging and guided stents for placement, and they pointed that out to me because they said, we want you to know that we wanted that thing angled. We wanted it angled. So they had followed their stents and wanted an angled implant in the front. We routinely do that as well in our patient population. But this is a 3-month post stage 1 with the framework in place, and an outcome that certainly they can be proud of, and I can be proud of as one who was treating this young lady who continues to be alive and well and do fine over 5 years out from her cancer operation and surgeries. Maxilla as well, implant reconstructions, and being able to have implant retained devices for our patients that have maxillary squamous cell carcinoma and have resection of the jaw for that. So what are some of our challenges, and what are some of the things I've alluded to? There's an evolving epidemiology and therefore a molecular basis for head and neck cancer. It's not just smoking and alcohol. There's genetics, or there's a virus, or there's something, but it's evolving. We're seeing young females with tongue cancers that we didn't see before. We understand the evolving nature of oropharyngeal, but we have yet to understand the evolving nature of oral cavity cancer. So we have new patient population. This alters our traditional risk factors. It's not just the 65-year-old smoker and drinker that I need to look in their oral cavity, make sure they don't have cancer. The 4 patients I showed you up front, one of them was an 18-year-old girl. How many of you treating an 18-year-old girl on a routine basis think, boy, I better check for oral cavity cancer? It's a different population than it was 10 and 20 years ago, and that 18-year-old deserves a cancer screening just as much as that 65-year-old. There are questions regarding the same or different disease. Histologically, it all looks the same under the microscope, but there is variable biologic behaviors. I have people that I expect to live for 20 years because they're stage 1 and have almost nothing when they present, and they're dead in a couple of months. I have people I think will be gone in a month, and they're still around after a major resection. And so there's variable biologic behavior because we don't understand what those markers are of aggressivity of a tumor. We have scientific advancement in mechanism and targets unquestionably. What Dr. Polverini showed you today, I mean, amazing. The research and the time and effort and energy and the knowledge that is brought forward through those types of endeavors. So I applaud Dr. Polverini and what he has shown you today in regards to science and what science is doing to bring us these answers. We know that targeted therapeutic strategies can help. Cetuximab, which is a target to the epidermal growth factor receptor, is the first drug in 50 years to make any difference in survival for head and neck cancer patients. Unfortunately, it was a 10% difference. But any difference at all, cetuximab, a monoclonal antibody to epidermal growth factor receptor, has actually increased the survivability of patients undergoing surgery followed by radiation therapy. When I think about oral cavity cancer, I think we're at the tip of the iceberg. And I know that's a really bad analogy because it is March 25th and 30 degrees outside, so let me switch. When I think about oral cavity cancer, I think about a hike I took with my two sons earlier this summer in the warmth of July in New Mexico, up to a peak called the Tooth of Time at the Philmont Scout Ranch. And at 9,000 feet, we witnessed the sun beginning to rise. And I think in regards to oral cavity cancer, that's where we are. We're beginning to see the sun rise. We're beginning to see and understand genetic markers better than we could before. Oral pharyngeal is leading the way, but oral cavity certainly can't be too far behind. When I think about the future of oral cavity cancer, I have glimpses of it. I have glimpses of the future of treatment of oral cavity cancer in looking at this picture where Dr. Edwards is using surgical navigation to assist him in doing a safe and appropriate resection for a young child in the operating room. The computers are guiding the placement of saws to be sure that he protects vital structures in this child while doing an aggressive surgery for removal of disease. When I think about the future of cancer, I again think about Dr. Edwards and Dr. Nick McCool, one of our chief residents, who are really championing the use of technology to enhance the treatment that we're rendering to our patients by virtual modeling of the surgical interventions beforehand. This is a place where we can't do what we call pre-plating. I can't put a plate on safely during the operation because the cancer is right there. And so instead, using technology, they can computer model this for me. And we can decide, here's where my cuts are going to be at the time that we're doing the resection. And not only can they do that, they can take the images from the fibula and they can model on the fibula where those cuts need to take place in ways that models can be generated, plates can be bent, and in the operating room, we can use this as a guide to show us exactly where the cuts need to be. Optimizing the surgical intervention, optimizing our time and energy that we spend with the patient, and allowing us to go from this in the leg to inserting that almost immediately into the oral cavity without making hardly any adjustments at the time of the operation. We're able to use mirrored image mandibles where needed to recreate, for example, here a condyle with a fibula. We're able to take very complex maxillary tumors for which there's no way that you could decide where the bone should go using plates or any markers that would exist at the time of the operation. But before the operation, using the images, they can use those images to design exactly where we need this fibula to go, create templates to help guide us at the time of the operation so that this can be an outcome with a maxilla exactly where we want it, and ultimately dental implants can be used for a restoration of this patient. We can use computer-guided modeling and imaging to create models that will help us understand where we're at and where we need to go in regards to dental implant placement, and our prosthodontists can use those models to do wax-ups and help us understand exactly where that bone needs to go. Some of the advantages of these modeling is it creates a palpable vision for our operative outcomes. The templates, as I mentioned, can be pre-bent. That adds efficiency in the operating room. It allows us to increase the precision of our osteotomies, enhances communication with our colleagues, augments the competence of trainees, and optimizes our efficiency in the OR so that the quality and quantity of the life of the operator as well might be taken into consideration. Operating time savings also ends up in a decreased cost savings. One of the big questions is, how much does it cost to do this? Well, if I can save a half an hour in the OR, I can make up those costs. And I can assure you on most cases, we're saving a half an hour or more in the operating room in using these technologies that are available to us. When I think about the future of oral cavity cancer and reconstruction, I think about what Dr. Feinberg is doing in the lab, using scaffolds to reconstruct mandibular defects. Here in a pig, to be able to reconstruct a condyle using a scaffold and bone morphogenic protein. I think about, again, Dr. Feinberg, who's also utilizing the expertise of Dr. Edwards in the microvascular surgical realm to be able to create lips and mucosa for soft tissue injuries. That scapula I showed you, it was a nice way to close the hole that we had created, but certainly there weren't any lips there. Looking at ways that we can create mucosa and create lips even after these types of major resections. When I think about the future, I certainly think about targets. I've talked about cetuximab. I've talked about a targeted therapy that is working. Dr. Polverini is looking at targets in the research that he shared with you today. I think about research that I was privileged to be a part of in my lab associated with the Michigan Nanotechnology Institute of Medicine and Biological Sciences. We were able to translate a nanodevice chemotherapeutic into head and neck cancer. This is a model of that therapeutic. Methotrexate is our agent that we're using as a chemotherapeutic, and folic acid was what we were using for targeting. We screened a number of cell lines kindly provided to us by Dr. Carey, and in those cell lines, it was predictable. If the cell line had no folic acid expression, then the targeted therapy didn't have any effect whatsoever. If the cell line had moderate amounts of folic acid expression, then the tumors were moderately sensitive to the nanodevice targeted therapy. And if the tumors had high amounts of folic acid expression, then the tumors were highly responsive to the targeted chemotherapy. We moved this into the realms, comparing it to methotrexate, and found that we could deliver 3 times the normal dose, and that the profile in regards to the toxicities were much, much less. This is an animal receiving a targeted methotrexate in which their tumors have better control, but they show no signs of the systemic toxicity that we see with the free methotrexate mice. When I think about the future of oral cancer, I think about astounding and great researchers at the University of Michigan School of Dentistry. Dr. De Silva, Dr. Capilla, Dr. Noor, Dr. Teschman, among them. They're looking at biomarkers, they're looking at targets, they're looking at stem cells, they're looking at how cancers get to bone, they're looking at targets as Dr. Polverini presented today. And I think of the future of oral cavity cancer, and I think of the power in this room to change the way we think about this disease because of the research that is going on. When I think about oral cavity cancer, I think about these folks. The people who are kind enough to put faith in me and the people I work with to treat their disease. My answer to my patient's question was, in 2010, I've told you what we know and what we have to offer. Hopefully in 2020, 30, and beyond, science will give you and I answers that will make us question why we are doing what we are doing today. For now, I recommend we make a jaw out of your leg and see if you need radiation or chemotherapy and radiation in addition to your surgery. So I thank that gentleman who trusted for me to take him to the operating room and offer him that treatment. And I thank all of these individuals who I've shown you today who are oral cancer patients of mine. Unfortunately, folks, 4 of them are gone. And they're gone because this disease still claims the lives of more than 50% of the individuals that present with it, despite the fact of the wonderful treatments that I've shown you today. When I think of the future of oral cancer, I think about these folks, the residents that I have the wonderful opportunity to associate with on a day-to-day and week-to-week basis. I can't figure it out. They don't all want to be cancer surgeons. I don't know what's going on. But I look forward to the differences that they will make as they move forward in their professional careers, much like you, the dental students who sit here today, as you move forward in your careers. I think about the group here in front with hairs graying a little bit. The guy on the end already has gray hair. I worry about this guy in the middle. He's the program director, has an enormous administrative responsibility, operates more than any of us on our service, and is still kind enough to be the reconstructive surgeon for the majority, if not all, of the cases that I showed you today. When I think about the future of oral cancer, I think about these folks. What will it look like when they're in my shoes? Will we have changed this disease? Will it be different? Hopefully, there'll be the medical oncologist delivering nano-device-targeted chemotherapy. This guy wants to be an orthopedic surgeon. I think that's one of the risks of getting an MD is your children wanting to get an MD. They need to go into dentistry. But I think about these folks too because of the support that they give to me to be able to offer what I've shared with you today as treatment for my patients. And I couldn't do it without them. When I think about the future of oral cancer, I am grateful for the present and for the past, in particular, groups of individuals and organizations that have both supported my ability to be in the lab and work, and who have supported my professional development overall. And I leave you with this message. Early detection saves lives. There is nothing else that we have today in oral cavity cancer than early detection. And there is no better group to have that early detection than the people that sit here in this room. My guess is there's probably no better group at a school of dentistry in the nation either of scientists and researchers to make a difference in regards to oral cancer as we move forward as well. So I applaud the efforts and energy that goes in. I applaud what's taken place here today in regards to a grand rounds on a topic that I certainly am passionate about, and you may have sensed that in my time here with you. I thank you for your attention.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.